Can you hear me, Matt?
Yes, Charles, everyone is now muted.
Okay. Good morning, everyone. My name is Dr. Charles Moy, one of the ENT registrars at the University of Cape Town. Welcome once again to our Friday virtual grand round meetings. Today, I'm going to take you through our first case presentation. A few disclosures. So consent was obtained for the use of this patient's clinical data for this presentation. There's no intention for any copyright infringement, and my content is as well referenced. So I will straight away go to the history. I'm presenting baby ST, whose first contact with us was at day 3 of life, with the presentation of respiratory distress, and on background, this baby was delivered via normal vaginal delivery at Vanguard Hospital. That is one of our district hospitals. And then 30 minutes, the history was that about 30 minutes after birth, the child started desaturating. They put the child on high flow nasal cannula oxygen, and there were ongoing desaturations, and they decided to airlift the child to Curtis Care Hospital, one of our tertiary hospitals. So in terms of what transpired at Curtis Care,
Charles, we've just lost your audio. Can you just check your connection and check that you're not on mute?
with a bit of relief when the baby was crying. And of note is that this baby was unable to breastfeed and was being cup fed. But soon after the cup feeding, there was worsening of the respiratory distress with associated irritability and agitation. So they then subsequently changed from high flow nasal cannula oxygen to a nasal continuous positive airway pressure. And then the child coped for a period of plus or minus 24 hours before failing. So the information from the referring doctor was that there were periods where the child was actually more stable on nasal continuous positive airway pressure. But however, it wasn't satisfactory. And later on, they then attempted to pass a 5 French catheter nasally, and they failed. And then that is when they inserted an oropharyngeal airway, and then subsequently orally intubated the child with a size 3 and cuffed ETT. They then referred the child to Red Cross Children's Hospital for further management. So again, of note, from the background history, this child was retroviral disease exposed, but it was a low-risk exposure. The child has been called by the ICU team that the child has been referred to them. Maybe any checkers in terms of how were they going to approach this case? Any exam candidates wants to take it on?
Charles, can I ask you to just repeat that question? Quite a few of us here lost connection. There's a bit of an unstable connection here at the moment.
Okay, so I was saying I'm opening the question up to the exam candidates in terms of wake-up. You know, this child has been received by Red Cross Children's Hospital ICU team and they call you in that the child is there. I mean, how for the exam candidates, how are they going to approach this case? If you're perhaps on call and you're called in, the child is already admitted in ICU from there.
Rafael is here to respond to your question.
Hi, Charles.
Yes, you can take it on, Rafael.
Okay. I think the first thing we'll do is to do a general examination of the child. And then you note for any dysmorphic disorders like any midfacial hypoplasia and so forth, and any like retracted mandible and so forth. Just look for any cause of any airway obstruction. And then, then you can do an examination just to check the patency of the nasal airway. And you can do it in two ways. You can either use a cotton placed in each nostril and not the movement. And then you can also put a metal plate in front of the nose and then check for any misting of the nose. And then I think once you've made the diagnosis, since you gave the diagnosis away, that it's a choanal atresia, then the next logical step will be to do a CT scan. This is to distinguish between a membranous cause of atresia and a bony cause of the atresia. I think that's what I would do.
Thanks,
any
Rafael.
additions? Any additional tests or?
Charles, I mean, once you've perhaps confirmed the choanal atresia, you'd want to exclude the associations with charge syndrome. So perhaps ophthalmology consult, a cardiac echo, a renal ultrasound would suffice, as well as audiology, obviously, to exclude any associated ear abnormalities. And then obviously prior to that, like you've done, you'd want to secure the airway. First line would be to use an OP airway. I think what's also described is to use a cut-off McGovern nipple of a dummy or a bottle. And if you cannot maintain the airway in that way, then you must proceed to intubate the patient orally, obviously.
Okay, close connection a bit. Okay, shall I proceed, Matt?
Yes, please.
Okay, so we proceeded with an examination of this baby. So the baby was fairly stable on mechanical ventilation. He had an orogastric tube for feeds in situ, required minimal ventilator support, FiO2 21%, a PEEP of 5, SATS of 99%, and the child was aparaxial. In terms of e-examination, otoscopy was normal, and the external, auditory canal as well as the penis were also normal. And oral cavity, there were no cleft lip or cleft palatal deformities. The child was intubated, but there was no high arch palate, and the oral cavity was fairly normal. And this child was non-syndromic and didn't have any dysmorphic features like micronathia, low-set ears, or any features suggestive of the craniofacial stenosis. In terms of eye examination, cardiovascular examination, CNS and urogenital examination was also unremarkable. So in terms of the nasal examination, we as well could not pass a 5-French catheter through the nose bilaterally. And there was this dense gelatinous string of mucoid secretions, which we cleared. We irrigated the nose and decongested the nose prior to the CT scan. And then we did a flexible nasal endoscopy as well, which confirmed the bilateral atretic plates posteriorly with the congested nasal cavities. So again, I will maybe the other exam candidates can take this on in terms of the differential diagnosis of nasal obstruction in a neonate. What are their thoughts?
Is there anyone online who'd like to take this question? Okay, Charles, if there are no takers, I'll attempt this. So your main differential, as Raphael already mentioned, would be choanal atresia, as well as congenital piriform aperture stenosis. I think you also get forms of mid-nasal stenosis associated with craniofacial abnormalities. Then rarely you may have a traumatic or congenitally deviated septum, which would be more in keeping with a unilateral stenosis, obviously. And then you've got masses which may occlude the nasopharynx, so dermoids, encephalocele, meningoencephalocele. Less commonly, things like Thornwell cysts, craniopharyngiomas, tumors, teratomas, chordomas. And then you have obviously acquired forms of stenosis, which would be a lot more uncommon in a newborn.
Okay, thank you very much, Dr. White. I think that's pretty much about it. So in terms of the differential diagnosis of nasal obstruction in neonates, they took this table from Scott Brown. So you can divide them into congenital causes, acquired causes. Then in terms of congenital causes, you have got your anatomical and skeletal anomalies, like choanal atresia is high up on the list, things like piriform aperture stenosis, mid-nasal stenosis, nasal agenesis, craniosynostoses syndrome, cleft palate, deformities which may cause, abnormalities of the ala of the nose or septal abnormalities. So you can also have congenital nasal cysts, for example, dermoid cysts, nasolacrimal duct cysts, Thornwell cysts, nasoalveolar dentigerous or mucus cysts, and you can have nasal masses, as you mentioned, Dr. White, like bilateral, meningoencephalocele, hemangiomas, teratomas, chordomas, and hematomas. And then also have acquired causes, structural causes, osteocartilaginous nasal deformities. Usually these ones are common in normal vaginal deliveries where there may be trauma to the nose, giving you a neonatal obstruction, as well as you may get inflammatory conditions like neonatal rhinitis, which is highly unlikely in this case. So I think we've just mentioned some of the investigations which you may have because of the association of choanal atresia with Church syndrome. So you want to exclude other features of Church syndrome. So in terms of radiology, you want to order a CT scan. So it is of paramount importance that prior to the CT scan, you want to decongest the nose, and you want to apply decongestant about 30 minutes before the scan. You want to suction the nose immediately before the scan as well. And the purpose of your CT scan, you want to confirm the diagnosis if it's unilateral or bilateral choanal atresia. You want to evaluate, the airspace distance in the posterior choana and the width of the voma. And you want to assess if your atresia, is it a bony, or is it a mixed, or is it a membranous atresia. And you want to exclude your differential diagnosis, which I mentioned previously. And you want to also evaluate for associated anomalies, with the association of choanal atresia with Church syndrome. You also want to exclude, ear abnormalities or other craniofacial abnormalities. So this was the CT scan, which of our patient, which was done. This is the axial cut. So as you can see, this was a mixed picture. As you can see, there is this posterior, medial bowing of the maxillary, of the walls of the maxillary sinus, and this air fluid levels, kind of like confirms the membranous part of your atresia. And again, it it is important that you measure the airspace distance in the posterior corner, and corneal atresia is confirmed if your airway space is less than 3 millimeters bilateral. And we also looked at for the ear to exclude associated malformations in view of the association of corneal atresia with the charge syndrome. These are just a sagittal view and an axial view just to show you this the atretic plate and the obstruction of the posterior corner. So again, if you don't have a CT scan, you may well use an X-ray in centers which cannot access a CT scan. So you can fill the nose with a retro-opaque dye, and you can then demonstrate a hold up of dye in the posterior nasal cavity, as in this instance. So this is important if you can't access a CT scan. So in terms of other investigations, I think you've already mentioned this. You can get an ultrasound scan, kidney, ureter, and bladder. You want to exclude any urogenital malformations due to the association of the corneal atresia, especially bilateral corneal atresia with Char syndrome. We want to do an echo to exclude cardiac anomalies. So an echo is as well important pre-operatively, because it has been shown that the presence of cardiac anomalies in a patient with bilateral corneal atresia is the risk for high mortality and morbidity. So we want to do an audiological assessment as well as ophthalmological assessment in view of association with Char syndrome. So I will straight away go to the videos of this case. So we approached this case transnasally and with an endoscope, and so after decongesting the nose and infiltrating, so we did a crossover flap technique. So this is the right side where we are fashioning an inferiorly based mucoperiosteal flap. So we used a sickle knife for initial incision. And then we elevated our inferiorly based mucoperiosteal flap. So we use some otology instruments as well. So here we used a suction plaster knife. So we lifted the flap until we reached the junction of the vomer and the palate, the palatal bone. And then we elevated the flap until we had a view of the posterior funnel opening. So this video just shows, we elevated the flap, the mucoperiosteal flap until the view of our nasopharynx. And then this video shows how we then fashioned, on the left side, we fashioned a superiorly based flap. So this is how we made our incision. This is how we made our incision. and I will try and skip some of the videos if there's really nothing much of note. So at this side, we patient on the left side, we patient is a superiorly based mucoperiosteal flap, and then we used the microdebrider to widen the posterior choana. Initially, we had attempted to use the ball tip backbiter, but we failed due to the space was quite narrow. So, and then as you can see here, initially we couldn't even pass the mushroom backbiter. So we used the microdebrider to widen the posterior choanal space. And then we proceeded to do a posterior septectomy. So this is how we proceeded the posterior septectomy. We're still fashioning our posterior septectomy. Okay. And then after the posterior septectomy, this is basically how so this is basically how it then how the posterior choana looked like. So we took the posterior part of the septum and then we widened the posterior choana. So we used a microdebrider to take out part of this lateral wall, and as well as a micro caisson punch to widen this area. So this is basically how it looked like. It was then, as you can see, this was the source palate there. So this is just a picture to show how the posterior choana area as well as the nasopharynx looked like after the operation. And then post-operatively, the patient was taken back to ICU and successfully extubated after 24 hours. So this is our standard of practice protocol on how we manage these patients post-op in ICU. So we use normal saline irrigation every 2 hours, and regular nasal suctioning. We use Bilateral drops as well as FML drops. So at this point in time, I will open this for any comments and questions from Dr. Pia.
I wonder if we should ask Prof. Libbe to comment on just the flaps, because she's the one who's taught us that. We follow her technique. Is Prof. still around?
Hi, Shaja, can you hear me? Sorry, I'm just on the move.
Sorry.
Yeah.
Yeah, I just thought you could tell us about the flaps and how you make that posterior septectomy.
Yeah, I think there's some important things is just with regarding to starting your flaps or starting the dissection. When I started, I always used the endonasal drill, but you actually have to be very careful, to use the drill unless you have a microdebrider drill where just the tip of the drill is exposed. Because otherwise, if you have the shaft of the drill exposed more than 5 millimeters, that can heat up like the floor of the nose. And we've had patients in the beginning that presented with fistulas. So I think it's very important maybe to stay away from power tools unless you have the right ones. Then, so I use a hammer and chisel to remove that posterior part of the septum. So regarding the flaps, what flap you use, I think depends on the amount of space you have. You know, sometimes it's really, you have so little space. So you have to really decide if there is enough, you know, to do it like you did it in that case. But ideally, you just want to be able to cover all your bony, bare bone. So I think if you can manage to do that, you know, with whatever flap, and the one that's the easiest, I normally try and find that area where you would normally puncture right at the floor of the nose. So you stay against the septum and then go all the way to the posterior aspect of the nasal cavity. So when you're in that corner, sorry, let me just put my thing back on. So when you're in that corner of that area, you'll start raising your flap, going over the, so basing it more laterally. So you'll make your cut like up, most posteriorly up towards the septum as far as you can, because you're going to remove that part of the septum. So if you only need about 1 centimeter of that posterior end, you don't want to come too far anterior, because then you might sit with a kind of a significant perforation. So you go right posteriorly and then go up the septum, and then come make your incision anteriorly for about 1 centimeter and then come down. So your flap is actually based laterally, because then when you remove that posterior part of the septum, you can lay that flap, you know, over towards the other side, if that makes sense. I think the most important thing is just to try not to leave bare bone, because you can't really debride kids, you know, unless you bring them back to theatre. So ideally, you want to do one surgery where you don't need to bring them back. So you can do the flap on both sides, but usually, you know, because it's such a kind of small nasal cavity, you actually just need to harvest on one side. So if you can do it on the one side and kind of lay that flap aside, then you can remove the mucosa on the opposite side. So once you've removed that mucosa, then a small little chisel is almost the easiest to work, like a 2 millimeter chisel, where you just kind of puncture through. So in this case, it looked mostly membranous, very thick membrane that you had to go through. So you puncture through that. And then that posterior, you just need 3-4 millimeters of that bone. And I find that is much better than a drill. And then we don't stent. So with the cases that I've done, we don't stent.
Yeah. So I think if you want me to add to that, I'm happy to add to that. I think that's probably the simplest and the most effective, because to be honest, there's only one side that's wide enough. Usually we find with these children, it's so crowded in there that there is only one side that's wide enough and sufficient to make the flap. So Darlene, you're saying that you lay it back once you've created the stoma, you lay the flap back, and that pretty much integrates to cover any exposed bone. If what I would usually do in children who have very narrow cavities and where it's very difficult to get the endoscope in and a tool, I would usually use a dilator and puncture a hole. And then once I'm in, I would then go in with my instruments and at least follow through. But you want to make sure that you get medial and inferior. I think what's also a challenge is what we used to do in the past was we used to stent because we wanted to keep it open. But if you create a sufficient enough hole with the posterior septectomy, you actually don't need to stent it to keep it open. And I think Charles will continue with just discussing there's a meta-analysis from 2016 regarding to stent or not to stent. And the study shows that there are comparative outcomes with stenting versus not stenting. And we've decided, just moving on from 2016, we just don't stent and just follow these children up closely, so that there is obviously a risk of restenosis, but to catch it before they become symptomatic.
Yeah, so I agree, Shazia. So if you don't have that circumferential kind of trauma that you get with just puncturing it, or like we did it in the old days with the laser, you know, then I think your risk of stenosis is so small, because you've got such a big defect there from the one side to the other side. You know, it's more than probably a centimeter. So there's very little chance that that will stenose. Just another trick, you know, I always use a 4mm endoscope just because I can see better. And that's why the small little chisel kind of fits in with that. But if you use a 2.7, it gives you a lot more space. But to use a endoscope and a power tool, you know, there your visualization becomes really tricky, and that's where I think your risk for bilateral fistula comes in. So I would kind of advise people to stay away from shavers and drills.
Yeah, I mean, I think it's also, you know, with just the ala, the nasal ala and the entry point into the nose also is at risk with those things, you know, because you're looking up at the screen and you've got this tool, and just the everything is so small that it's probably better you get more control over instruments that are not, you know, don't have a life of their own sometimes.
Yeah, I think, I mean, even for me, and I work, you know, sometimes 8 hours a day, 4 days a week with the endoscope. It's tricky to work in that age, you know, so unless you really do a lot of endoscopic work, I think you'll struggle. It's not for the occasional kind of sinus surgeon to try and do a choanal atresia with power tools, you know, so yeah, so just keep that in mind. You think it's easier, but it's actually not.
Yeah, no, absolutely. I think also what we found is that you just create a stoma, or you create a space and you let them grow a little bit. And the nose grows proportionately, and you can always come back in a few weeks when they're a little bit bigger, and you'll find that proportionately things are a little bit bigger, and you can nibble away what's left. You've got more space in there.
Exactly. That's if you wait a couple of weeks, it makes a massive difference to the kind of access you get.
Yeah, certainly. Thanks very much, Darlene.
Okay, thank you.
Thank you very much, Professor Libbe and Dr. Peer, for your comments. Charles, do you want to just present that meta-analysis in the interest of time?
Okay, thanks, mate. So I'll just straight away go to that to that meta-analysis, and then I'll leave the other stuff for a different discussion. So in terms of, you know, surgical approaches, you know, we have got a transnasal approach, or transpalatal approach. The transnasal approach being the most commonly used technique nowadays. Those other techniques, you know, they are now historic sublabial, transeptal, and transantal approach. But this, you know, from this Cochrane systematic review from 2012, they failed to identify any randomized controlled trials which compared various surgical techniques. So their conclusion was that there was no evidence, you know, based on randomized controlled trials to demonstrate any advantages or disadvantages of any of the surgical techniques. And then this article, basically, this was a review which showed that, you know, the transnasal and transpalatal approaches, the initial success rates were similar, as well as nearly half of all the choanal required a complementary procedure as well. So, and again, I looked at, you know, the predictive factors for success after a transnasal endoscopic treatment of choanal atresia. I took this article from 2008. I'll just go into, you know, the conclusions. So the predictive factors for stenosis, they found that gastroesophageal reflux, age less than 10 days of time of surgery, in insufficient post-operative endoscopic revision were predictors of poor, you know, predictors of stenosis. However, this systematic review, it was not in agreement with that previous article. So in this systematic review, they showed actually that there are significantly higher success rates of treatment failure with delayed surgery for a bilateral choanal atresia. And again, to stand or not to stand, this was a systematic review which was published in 2016. So, you know, there was, in terms of success for bilateral choanal atresia, stenting with a 65% success versus no stents with a 64% success rate. So the success rates were comparable. However, the use of stents was associated with allied injury, colamellar tear, vestibular stenosis, and the stent blockage or dislodgement. And there was no sufficient data to determine if use of metamizin as an adjunct to surgery was actually useful. So, in the interest of time, I'll just try and summarize. So, you may want to go and look at this International Paediatric Otolaryngology Group consensus recommendations from 2019, which basically, they discuss the diagnosis, pre-operative, operative, and post-operative review of how we approach choanal atresia as well. So, in the interest of time, I will end my presentation here. Thank you very much for the opportunity.
Thank you very much, Charles, for a very interesting talk. Just a reminder to everyone to post your questions on the group or use the raise hand function if you have any. Professor Fagan, Professor Libbe, or Dr. Pierre, would you like to make any closing remarks? Perhaps one question, is there still any indication for the transpalatal approach? I don't know, perhaps where you don't have endoscopic resources, or under any other certain situations you may consider doing a transpalatal approach?
Do you want me to answer that, Matt?
Yes, please.
Okay. Basically, the transpalatal approach, it's quite tricky because it comes with its own adverse events. It's usually indicated in patients who have a unilateral choanal atresia that's presenting later on, and where you need to do some bony drilling, and the actual floor of the nose needs to be thinned out. So a retrograde view with a 70-degree telescope is actually quite effective, and we would use the Dingman gag, which is used by the plastic. It's really, really good. But obviously with advancing rhinology specialty services, people still continue to do them transnasal. So that's one of the definite indicators for transpalatal. I think there just is obviously some morbidity associated with opening the soft palate and the hard palate retrograde in a very small child. It really is difficult. It really is, which is why even cleft surgeons choose to wait a good couple months before they go in and repair cleft palates. Your risk, obviously, at that stage of wound breakdown and fistulas are high. So that's not necessarily a great alternative in a very, very young child. But I would be keen to see what the other countries choose to do where there aren't any resources for endoscopic sinus stuff. Just with regards to, just specifically with choanal atresia, I think what is very tricky is that it's not a common disease. And so it's important to have a referral center with these resources where patients like this can get transferred to, and specifically where there may be an underlying syndrome. Those children you may find have poorer outcomes, and studies have always shown that. So premature children, children who are very small weight, wait for them to get older before you repair because the outcomes are not as good. Syndromic kids with low-lying skull bases or who have other conditions associated with the midface also don't do well. So rather trachea those kids and wait for them to grow and do them at a later stage. And also, as Darlene mentioned, with the power tools, millimeters count. If those of you do subglottic stenosis, you know millimeters count. So in the same way at the back of the nose, millimeters count. So less is more. Try not to be too aggressive with taking out too much soft tissue, because you do get nasopharyngeal stenosis. We've seen it. We've seen closure of the back of the nose. And so there must be a level of delicacy when taking out the back of the bone with the mucosa, because that can cause irreversible stenosis. And in children, if you do less, you can always come back and do more later. So always bear that in mind with congenital conditions. Thanks, Matt.
Thank you very much, Dr. Pierre. Just on that note, I'd like to invite anyone else who has experience from any other countries or institutions to please either raise your hand and or post your comment, and at the end of the next presentation we can perhaps revisit that. So our next presenter is Dr. Simon Honnett, who's a registrar here at UCT. Simon, if you'd like to please share your screen and proceed with your case presentation.
Yeah, thank you very much, Matt. Is that on?
Yes, Simon, we can see your screen.
Great. Thank you very much, Matt, for the introduction. For today's, for my presentation today, I've got a bit of an unusual case. It's a little bit complicated, but Miss TS is a 9-year-old girl who had complained of about a 1-month history of right-sided headache, unilateral, and retroorbital pain. And the retroorbital pain was worse with upward gaze. It was not relieved by paracetamol. And she had also had a recent ptosis that had actually resolved spontaneously before presenting to us. Past medical history was completely unremarkable. All her immunizations were up to date, completely normal development, and she was taking no chronic medication. She was in grade 3 and doing fine in school. She was alert, apyrexial, completely ambulatory, no lymphadenopathy, no hepatomegaly or splenomegaly. Cranial nerves were all normal. Signs, so no proptosis, chemosis, ophthalmoplegia, no redness, and normal visual acuity and visual fields. And rhinoscopy was completely normal. On oral examination, she had no trismus and a completely normal oral cavity. So basically, the entire examination was completely normal. Just the unilateral headache and retroorbital pain with upward gaze. Her inflammatory markers were very slightly raised white cell count, but otherwise completely normal. So that's not very much to go on in terms of figuring out a differential diagnosis. We've got a headache and the recent history of ptosis that had resolved. So if we look at an approach to a differential diagnosis of headaches in children specifically, the headaches would be classified as primary or secondary, where primary are migraines, tension type headaches, cluster headaches, and daily persistent headaches. And headaches secondary to sinusitis is obviously very common, TMJ disorders, intracranial lesions like hemorrhages, strokes, arterial dissections, or tumors, and secondary to any generalized medical condition. So the indications basically for investigation of a headache in a child would be first presentation of an acute headache or a chronic progressive headache. The progression does warrant further investigation, or headaches in association with drowsiness, confusion, loss of consciousness, nausea or vomiting, any eye signs, or focal weakness or personality change. So we certainly had enough of an indication in Miss TS to do some further investigations with the fact that it was a first presentation of an acute headache and also the recent ptosis. If we just look at briefly the retroorbital pain that is worse with upward gaze, I had a chat with our ophthalmology colleagues with whom we share a ward, and they said that obviously optic neuritis is a very common cause of that, but in children, optic neuritis is firstly quite uncommon. And if children get optic neuritis, it's much more commonly a bilateral disorder than in adults. And in children, it would often present with a rapidly progressive, severe visual loss, which this child obviously didn't have. Secondly, any inflammatory disorder involving the extraocular muscles can present with pain with movement in any direction of the extraocular muscles. So if we have a look at the CT scans, first of all, a coronal cut from anteriorly. Oops, sorry. If we just move very slowly through the coronal cuts and pause on the important spots, we see that there is a concha bullosa on the right middle turbinate. The sinuses are pacified until we get to the posterior ethmoid sinus that is, sorry, the posterior ethmoid sinuses are pacified. And there is a extensive pacification and bony erosion of the sphenoid sinus and also area of the Vidian nerve, foramen rotundum, and heading back towards the pterygoid plates. And there was also a concern of possible bony erosion through the base of skull. So that's it on the coronal. On sagittal, sorry, axial, going down from the top, we see a pacified posterior ethmoids. Sorry, I'm not very good at driving this thing. A pacified posterior ethmoids and sphenoid sinus can be seen over there, and some bony erosion around the right orbital apex. Going further down, there's extensive bony erosion in that region posterior to the right orbital apex and extending into the infratemporal fossa on the right. Also bony erosion of the pterygoid plates. You can appreciate a difference between the right and the left, certainly. Sorry. So then on a sagittal, you can see some pacification of the posterior ethmoids and sphenoid sinus, a possible bony erosion in the base of the skull, and the highlight of the coronal is this pacified sphenoid, and certainly in the area of the Vidian canal and foramen rotundum, and the orbital apex seen on the axial scan. So we also did an MRI with the concern of the possible breach of the base of skull, but the MRI confirmed that the base of the skull, confirmed that the dura was intact. There was no intracranial or intradural extension, but we did also see on the T1 gadolinium enhanced scan that there was some enhancement of the lesion extending down towards the infratemporal fossa on the right-hand side. So if we, I'm not going to put any exam candidates on the spot because it really is quite an uncommon sort of presentation, but if you think of a differential diagnosis for a central skull-based lesion presenting during childhood, so it's not a congenital disorder, and with bony erosion as opposed to the bony remodeling, the differentials, the main differential would be a rhabdomyosarcoma, particularly because of its characteristic erosion of and centered in proximity to the pterygoid plates. So rhabdomyosarcoma would be right up near the top. Other soft tissue sarcomas and bony sarcomas could be part of the differentials. Metastatic neuroblastomas can occur, but more commonly involve the orbit. Chordomas and craniopharyngiomas can be part of the differential. And then, of course, lymphomas and leukemias must be in the differential. So we took the patient to theatre initially just for a limited examination and anesthesia and a transnasal biopsy. And at the same time, obviously, considering that it was possibly a rhabdomyosarcoma, also for a staging bone marrow aspirate and trephine and lumbar puncture as part of the staging workup. And the histopathology results surprisingly actually confirmed juvenile aggressive fibromatosis, which is quite an uncommon disease. So hence the presentation for today on the ward round. Bone marrow aspirate and CSF both showed no malignancy. So if we look at the disorder of juvenile aggressive fibromatosis, it's a rare condition, basically characterized by desmoid tumors, which are tumors arising from fibroblasts. Obviously, you get fibroblasts all throughout the body, so the tumors can be anywhere in the body. They don't metastasize, so strictly speaking, it's a benign disorder, but it is extremely locally aggressive, which makes the treatment quite challenging. The disorder is mostly sporadic, but if a patient presents with multiple desmoids or abdominal desmoids, one could consider an association with familial adenomatous polyposis, and if there's extra abdominal desmoids, then that could be part of Gardner's syndrome. You can get desmoids during and after pregnancy as well, because of the thought to be because of the high estrogen levels, but the etiology and pathogenesis are not known. Histologically, these desmoids are similar to low-grade sarcomas, but like I said, they don't metastasize. So the treatment options basically can be summarized as, if the patient is asymptomatic and it's an incidental finding, one can consider watch and wait, but bearing in mind that it does tend to be quite locally aggressive. So the watching part of it must be very closely monitored. If the desmoid tumors are symptomatic and operable, and the patient is fit and healthy for a general anesthesia, then most people would recommend a surgical excision, but obviously taking wide margins, because there is a high rate of recurrence. You can also add in adjuvant radiotherapy as a post-operatively, but that is controversial. Some people say if you find positive margins on the histopathology, then that would be an indication. Other people say you would only add in adjuvant radiotherapy if there's macroscopic residual disease that you've deliberately left, for example, over the optic nerve or carotid artery or something like that. But either way, the whole issue of adjuvant radiotherapy has limited evidence to support or refute its use. Then if the tumor is symptomatic but inoperable, or the patient is not fit for anesthesia or prefers not to have an operation, one can consider systematic either radiotherapy again, but what one must also consider, obviously, if that's going to be your primary treatment, then the risk of late radiotherapy side effects, particularly radiation-related fibrosis in the area, particularly around all those cranial nerves, and secondary malignancies, particularly if you're starting your radiotherapy in childhood. So the other options in terms of systemic treatment, the chemotherapy is one of the modalities, which would generally be reserved for tumors with life-threatening complications. So you can either use doxorubicin or PLD, which is pegylated liposomal doxorubicin, methotrexate plus vinblastine, or cyclophosphamide. Some of the other systemic treatments, not chemo, so then sort of reserved for non-life-threatening tumor growth, would be tyrosine kinase inhibitors. Hormonal treatment, like we said, there's a possible association with high estrogen levels and driving the desmoids in and after pregnancy. So then anti-estrogens and selective estrogen receptor modulators, like tamoxifen, with which we're all familiar with breast cancer. And non-steroidal anti-inflammatories have also been used, but obviously with some people showing a resolution of symptoms on non-steroidals, but obviously there's not enough evidence to have a randomized controlled trial to show that it was the non-steroidals that caused the resolution as opposed to just a placebo. But non-steroidals are listed as one of the systemic treatments. So obviously in our particular patient, she being 9 years old, generally fit and healthy, but with clearly a symptomatic desmoid, we decided to take it to theatre to do a right sphenoethmoidectomy. So if we just start through a couple of slides from the surgery, the lateral wall is on the left of the picture and septum on the right of the picture. There's that middle turbinate concha bullosa that we saw on the CT scan coronal slice. So that was limiting the access to the uncinate and middle meatus. So we first incised the concha bullosa and reduced it laterally to gain access to the posterior part of the uncinate with a ball probe, reflect the uncinate forwards to be able to do a middle meatal antrostomy. So there's the middle meatal antrostomy being created. Here is then the middle meatal antrostomy on the left of the picture, and in the center of the picture is the sort of anterior and posterior ethmoids having been removed, the wide sphenoidotomy, suctioning out blood, and then underneath that is the abnormal looking tissue. So we did extensive sort of debulking of the tumor, going all the way from lamina papyracea all the way up to the base of skull, to remove as much macroscopic disease as possible. That's the end of the presentation. We obviously are awaiting further discussion with the various other disciplines, including pediatrics and oncology, to see about the potential for further systemic treatment if it's necessary. And we haven't yet seen her post-operatively in the clinic, but it'll be very interesting to see when she does come back to the clinic. Thank you very much for the opportunity to present. Does anyone have any questions?
Thank you very much, Simon. That was a very interesting presentation. There are no questions so far with regards to your case. Dr. Pierre, would you like to make any comments regarding the management of this patient?
Yeah, thanks. Thanks, Matthew. I think perhaps the reason to present this is just to put into perspective the spectrum of pediatric sinus conditions that present with tumors and masses, and how to approach them. It is very rare, and this specifically, desmoid tumors are even more rare than others, but we always have to exclude malignancy, and specifically a rhabdomyosarcoma or a lymphoma and conditions like that, which require urgent intervention. So an approach to a sinonasal mass or a sinus mass in a young child, it's important to get have a plan for that. And I think specifically with this child, she was otherwise healthy, but she did present symptomatically. To take all of that and to immediately refer to a center that can do imaging, specifically CT and MRI, and to have a multidisciplinary team set up for conditions like this, to have the pathologist around so that the tissue sample is representative, and to have a subspecialist. So even though we do the biopsies, we always have Prof. Libba around because she's a skull-based surgeon. And so as in this case, clearance is important. So when we initially did the biopsy, which was just transnasal, we did a sphenoidotomy, we just got inflammatory tissue, and it just didn't make sense. So when we went back, we went to Prof. Libba and we did a complete FES on that side to the point where we could see the lamina papyracea, the skull base, and did a complete sphenoidotomy with the sphenoid face looking back at us. So we were happy we had on block clearance enough to get tissue to send for histology, so that we were able to say, no, there's nothing more we can take. And the histology came back with extremely rare diagnosis. So even though it's a benign condition, it's on the spectrum of low to intermediate sarcomas. And the reason why, even though it's benign, it is something to keep watching is because it has no metastatic potential, but it's locally invasive. And so why I emphasize the need for a multidisciplinary team and the need for having specialist ENT services is that when we do go back, we have to know that whoever started the dissection will know where to follow on. And so Prof. Libba will help us again with getting into the infratemporal fossa. The problem with conditions like this is the morbidity is so high if you keep scaling down and removing tissue. So at this stage, because the child is so young and there aren't any sequelae from just having taken a wide biopsy, we're going to opt to wait and repeat the MRI in a few months' time. She's got no neurological fallout. She's actually otherwise healthy. And the oncologist has decided to start her on medical therapy, so no chemo, and to wait and see. Radiotherapy is not advised in this age group because of the cosmetic sequelae associated with that, and especially in children for this condition, it's not as effective. So the second option now moving forward would be either radical surgery or to give her a trial of chemotherapy, and that would be then monitored using 2D and 3D images to see tumor shrink as a solid growth. And then we would decide, are we winning here? Do we need to go back and resect what's left? And for now, all we've got is that laminar paprasia and the extension into infratemporal fossa. She's still got sensation of the infraorbital nerve, and her vision is entirely normal. So we're going to just watch and wait.
Thank you very much, Dr. Pierre. Professor Fagan, would you like to comment?
Yeah, thanks very much. It's a very interesting case. It's I'm just questioning whether any form of radical surgery has a role to play, because if you look at on the MRI, there were changes tracking all the way laterally towards the parapharyngeal space along the lateral pterygoid muscle, and I just can't see one actually being able to resect that entire skull base. And so the question just arises whether doing more endoscopic approaches is going to change the actual natural outcome of this patient's disease.
Exactly. That's why, Prof, we opted not to do anything, because always the oncologists want to know, is there anything more you can do? And we said at this point, there's no benefit to removing what's in the sinuses, because we can't in good faith track all the way down to the parapharyngeal space. So I agree with you. It was more just to give the non-ENT's perspective on
that. Thank you very much. Dr. Pierre, there have been one or two questions regarding the initial case of choanal atresia. I wonder if you could just entertain. The first one, well, two questions actually, was regarding the timing of extubation post-choanal atresia repair. Is there, in some cases, will you immediately extubate in the post-operative period, or would you wait a bit longer for the airway to settle?
It's always a tricky one, and really, to be honest, it's patient specific. We're always struggle with the ICU here with beds and early extubations, and I think you mustn't be pressurized by other people. If someone has transferred into your hospital and they have been intubated for a period of time, 24 or 12 hours is not going to make a difference. For me, the important factors to bear in mind, it's the timing of the surgery. So if you're doing the surgery early in the morning and you're, got enough people on the ground, you can decide to extubate the child in theater. My struggle with that is you've given the child an anesthetic and they've never breathed through their nose. So I would always leave it for a more controlled environment. I would send them back to ICU, and during that day, I would give them a trial of extubation. But I always say, especially in our ICU where there's a chronic short staff issues, is to never extubate someone if you can after 2 o'clock. They always do well for the first 2 hours and then they fail, and by then it's transfer of people and change over time. So I would always extubate within the first day of doing the surgery, but I would do it early in the morning. So if you're doing this for choanal atresia in the afternoon, I would extubate the next day in the morning. I think 24 hours turnaround time is not long. I would obviously want to make sure the patient is deeper and that they aren't wriggling around, because that gives you laryngeal trauma. So do it within 24 hours of having repaired the patient, but do it first thing in the morning if you can, or ideally before 12 o'clock. There should be no contraindication to extubating. There are obviously some schools of thought that say, well, you've put flaps in there, they may be bleeding, you've packed. In theory, you've created an open airway, so you should extubate within 24 hours.
Thank you very much. I think if there are no final questions, I'd like to invite Professor Fagan to make any last closing comments.
Well, perhaps we should leave the closing comments to Shazia because it's really outside my area of expertise.
Perhaps I'll just say one thing, is that it's important if you're doing pediatric cases to always lean on your subspecialists, because pediatrics, even though it's a subspecialty on its own, like Prof. Libber said earlier, you want to know that someone who's going into the nose has the experience to constantly pick up cues as they go along. So I have a very low threshold to call Prof. Libber for my head and my rhinology cases, because she's got much more experience and she's able to make clinical decisions in the nose that perhaps I would need assistance with. So if you have a subspecialist with that level of skill, always lean on them, especially with the complex cases, with the skull-based cases, and in conditions that would require further interventions. I think that's important, and that holds true for otology as well as for head and neck in children.
Thank you very much, Dr. Peer. So just to end, just thank you to the presenters and to the supervisors, Dr. Peer, Professor Libber, and Professor Fagan, for today's presentations. Just a reminder to fellow registrars or medical officers, if you're interested in presenting any interesting cases from your institution on this platform, please feel free to contact one of us. And then thank you, everyone. Thanks for today, and enjoy the rest of your Friday.